Thank you so much for that informative video. I think it's about time we get started. Welcome, everyone. If everyone, again, could please mute your mic, that would be great. You may, of course, keep your video on as you feel comfortable. You may also write some questions or thoughts in the chat as we want to keep this quite collaborative. But there will also be a Q&A segment immediately following the presentation where you can raise your hands using the Zoom feature, and we will call on you to ask your questions. For those who are affiliated with AIA, please know that you can receive AIA learning credits. You simply need to report that you attended this session. I just want to give a quick thank you to our sponsors, the Consortium for Sustainable Urbanization, UN Habitat, AIA New York Planning and Design, the NGO Committee on Sustainable Development New York, Habitat Professionals Forum for Sustainable Cities, Creative Exchange Lab, Global Urban Development, and the Columbia Center for Buildings, Infrastructure, and Public Space. Good day to everyone. My name is Naomi Parek, and on behalf of the Consortium for Sustainable Urbanization, it is my pleasure to welcome you to the first Green Cities event of 2025. We'll be discussing the AMORE Project, led by our distinguished speaker, Dr. Luis Gabriel Cuervo. Dr. Cuervo is currently a doctoral student in methodology of biomedical research and public health at the Autonomous University of Barcelona, where he has developed the research for the AMORE Project. A medical doctor and epidemiologist, Dr. Cuervo started the AMORE Project in 2020 as a response to inefficiencies in urban health planning. He also serves as the Senior Advisor Research for Health for the Pan American Health Organization. The Pan American Health Organization, also known as PAHO, is the regional office of the Americas for the World Health Organization, or WHO. In 2024, Dr. Cuervo was awarded the WHO Excellence Award for innovation for his work. I will let Dr. Cuervo share more about his extensive background in medicine and public health during his talk. PAHO is near and dear to me, as it was where I started my nearly 10-year career at the United Nations. I was an intern at PAHO in DC before moving on to a position at UNICEF, then to the Office of the President of the UN General Assembly, and most recently to UN Habitat. Later in my UN career, I was very pleased to work closely with WHO on the 2019 high-level meeting on universal health coverage. And now, for our featured guest, I am pleased to welcome Dr. Cuervo to take the floor to share his doctoral work with us.
Well, thank you very much, Naomi. I'm very grateful for the opportunity to join the Consortium for Sustainable Urbanism and to represent the AMORE Project Collaborative, which is celebrating its 5th anniversary this week. I am delighted to have you as our moderator. As we prepare for this event, we realized that our paths had crossed the Pan American Health Organization in 2012. In this presentation, I will address our session objectives by sharing our experiences in intersectoral collaboration. We have aligned, and I'm going to share a screen here, the agendas of various sectors and stakeholders to shape urban and health services planning. Social justice and health equity are the core of the approach that we have taken, effectively uniting our efforts across different fields. So I'm going to stick to my notes to be mindful of the time so that we can have a debate later, but I will provide the links for those interested in getting acquainted with the interactive platform that we have developed. It integrates open data from sources like Colombia Census, the Registry of Healthcare Providers, traffic analysis zones, and travel time big data from Google Distance Matrix API. The focus of my presentation will be how we developed a collaborative that supported intersectoral and multi-stakeholder collaboration and engagement. So my interest in this issue began with some personal observations. In many discussions and presentations about health services planning, often featuring academics and technical experts, I noticed that the focus is typically on the distance traveled and to reach the services. The presentations usually rely on isochrone maps showing average travel times or simple straight line distances. Growing up in Bogota, I remember it took about it took our carpool about half an hour to drive to class during medical school. Today, the same journey at the same time of the day takes over an hour, probably an hour and a half. For the past 22 years, I have relied on GPS navigation systems that are now readily available on smartphones and cars, even for routine commutes. And these systems constantly update travel times and routes to reflect current conditions, making arrival times a more practical measure than miles or kilometers in our daily lives. This raises an important question. Why do we use accurate, real-time travel data that accounts for traffic congestion for our commutes? And yet, health services planning still relies on methods that overlook the impact of congestion on different population groups and transportation modes. With this topic as a bee in my bonnet, I began my doctoral project as the pandemic started. We had to stay at home, and during my morning walks in the woods, I discussed the idea with my brother Daniel, a data analyst, and Lidia Osorio, a public health expert and innovator from Cali, where I studied family medicine. This spurred conversations with other interested parties, which is how I met engineer Ciro Jaramillo, who is an expert in mobility and geomatics, and Eliana Martinez, an urban health expert who later joined. So that's how we began. And as we reviewed the literature, we noticed that although the topic was relevant to several sustainable development goals, the sectors involved were not collaborating effectively. Research was often conducted in silos by homogeneous groups of specialists, and most studies were published in highly specialized journals with metrics, graphs, and formulas that are challenging to interpret and sometimes meaningless for the average citizen. Thus, we aim to create something accessible for policymakers. This required focusing on the policy problem, which might differ from the scientific question. Thus, it could involve employing multiple research methods that need to be outlined and looking at the problem in an integral way. It should present results in straightforward ways that intelligent lay people can understand, enabling various stakeholders to utilize them. In addition to describing the problem, it should test options to address it. Some policymakers have called for modeling results to be presented in interactive interfaces that allow them to test different assumptions. So we decided to incorporate these recommendations on making research useful for policymakers. They've been made by Chris Whitty, Seya Bimbola, the WHO, the Canadian Institute of Health Research, McMaster Health, and many others. So we decided to develop an approach with inputs from data and users. We also ensured our data scientists participated in discussions with data users as key informants throughout the process. So to achieve this, we needed to articulate our ideas clearly. With support from a museum science communicator, a narrator, and a Cali-based artist, we designed a logo, and we created a 4-minute animation. Distilling our complex ideas into a simple script that any educated person could grasp was a significant challenge that the animation and the animation that I'm talking about can be found in our Padlet, and we'll put the link in the chat. We published our thoughts on this in an editorial, and we decided to test our methodology in Cali, which is Colombia's 3rd largest city and the largest in the country's Pacific region. It connects the Pacific region with the rest of the country. This tropical Colombian city leans on the west against the Western Mountain Range and borders on the east with the Great Cauca River, so it lays in a valley. The tropical city is crossed from west to northeast by the Cali River. It has beautiful boulevards, and while this image may suggest it has a smooth traffic, that's not what it happens. The city has one of the heaviest traffic congestions in South America during most daytime hours, including during the weekends. The map to the right illustrates population density, closely correlating with poverty. Notice that low-income housing is predominantly located in the peripheral areas with high population density. Approximately half of the population lives in low-income housing, 41% in middle-income housing, and 9% live in high-income housing. Our team grew as specialists in equity, data sciences, urbanism, public health, social sciences, community engagement, consumer advocacy, including patient representatives, joined our efforts. We published a research protocol to invite contributions and created engaging infographics and multimedia, complementing the 4-minute animated video about the project. We also continuously improved our interactive platform by testing prototypes with target audiences and implementing iterative refinements. We developed a theory of change, which helped us identify key stakeholders and beneficiaries of our planned information and explore the drivers of change necessary to implement our work. We then identified 3 tracer services for the proof of concept in Cali, where Ciro and Lida were based and where I had studied. Cali is known for its strong civic organization. It also faces challenges related to migration, segregation, and social justice issues that contributed to civil unrest during the pandemic. So we selected tertiary care emergency services as one tracer service because timely specialized care is critical, such as when someone exhibits stroke symptoms or experiences a cardiovascular event. For critical ambulatory services, we chose hemodialysis and radiotherapy as tracers. These services require ongoing long-term treatment, and their direct and indirect costs can drive families into poverty. For example, individuals with terminal renal failure needed hemodialysis at least 3 times a week for life. So just imagine the financial and opportunity cost of commuting 80 to 120 minutes 3 times a week to reach a service. Adopting a people-centered approach involved engaging stakeholders across all levels of governance, from government and community advocates to civic organizations and service providers. So we intentionally contacted authorities and advisors in mobility, public health, and emergency preparedness, inviting them to participate in a conversation about developing urban and health services planning. To spark interest, we provided an infographic and a 4-minute video, which quickly generated further inquiries. During a meeting with the Deputy Secretary of Mobility and her team, our presentation was met with a profound silence. When I inquired about it, she explained that they had not realized the links between altering an intersection or a traffic light or a road with people's ability to access health services in a timely manner and with health equity. This insight spurred their engagement, and a team member later joined the collaborative project as a volunteer. So we observed similar reactions when we presented to service providers, to patient advocates, to former authorities and civil servants, academics, NGOs, and civic organizations. Soon thereafter, we were invited to discuss our approach with an urban observatory in Lima, universities in Colombia, and beyond, and at events listed on our Padlet. Our collaborative has about 50 volunteers, and we implemented our project without external funding. We partnered with Equartil, a data analytics company where Daniel, my brother, works, to host our website and develop our interactive platform. We built partnerships with research projects and NGOs working on related topics, which gave us access to personal testimonies and deeper insights into what accessibility truly means for people living in Cali's outlying areas. In these regions, residents often struggle to find reliable transportation for essential treatments, like hemodialysis or cancer. And they frequently face catastrophic health expenditures as a result. Testimonies such as Mrs. Margarita's added a vital human perspective to the quantitative data that we were gathering. We've targeted the scientific community by publishing or reporting highly accessed open access journals, adding recently visual abstracts and other methods to engage a larger audience, like the one you saw at the beginning of today's event. My brother, who's a certified data scientist, participated in a training course at Colombia's Ministry of Information Technologies and Communications, which included a competition. Well, together with his team, we developed a prototype that was a finalist of that competition. That was our first prototype, and now we have developed other ones. Our work was referred to the National Planning Department for its potential national application that has not yet materialized. But we also presented the WHO's Lead Innovation Challenge, where the project was a finalist. And we were able to join their boot camps and discussions with other innovators and experts that were extremely enriching. We then enhanced the prototype further by incorporating the inputs from potential end users. We published our accessibility results for the tracer services using infographics and multimedia to engage general audiences while producing scientific publications to validate our findings with academic audiences. In addition, we participated in events focused on data sciences, urbanism, health services research, quality of care, urban health, and other related fields, gathering valuable input and validation along the way. Throughout this process, we refined a prototype that allowed users to test different scenarios for each tracer service, letting the data speak for itself. It was essential to respect decision makers' role by enabling them to explore how outcomes varied based on different inputs and considerations. Our collaboration with Populab and the International Research Great Project through the Universidad del Valle was incredibly beneficial. We pitched our information tools to different audiences and shared our developments and results using diverse communication approaches. In 2022, we published our first results. They confirmed the value of considering traffic congestion in our assessments, because traffic significantly impacts accessibility to tertiary care emergency services, which static geographical accessibility assessments miss. So you can see how the map to the right changed as traffic was building up. This pattern was consistent across all our tested services. Our findings revealed that low-income housing residents and the poorest communities faced longer travel times and higher costs to access these life-saving treatments. The good news is that strategically locating new services could boost accessibility to levels comparable to those during off-peak traffic hours, or when you have free-flowing traffic, which is like 2 to 4 o'clock in the morning, effectively mitigating the impact of congestion. Well, serendipity has it that WHO presented its strategic approach to urban health last year, and we were ready. Our project is well aligned with its recommendations and follows the recommendations issued by WHO and UN Habitat to align the urban and health agendas. Universidad del Valle, the foremost public university in Cali, convened faculty and stakeholders to join our researchers in developing, in evolving those results to society. We were prepared, and the timing was perfect because Cali is drafting its land use plan and has published its 2024 to 2027 development plan. The strategic developments cite our findings and have the potential to spur change that brings service to communities in need. So far, we have found a receptive local government, a supportive civic organizations, and non-government organizations, and we are very hopeful. What have we reaped from working across sectors and disciplines? Well, our collaboration with partners like the Great Research Project and Populab, as well as the collection of testimonies, for example, those that were gathered by Dr. Diana Cuervo, who's not related to me, has provided critical insights into the challenges faced by residents in Cali's outlying areas. These communities often contend with harsh work conditions and inadequate transportation networks. They're forced to rely on expensive private or public hire cars for essential services, often at the expense of their autonomy. The diverse expertise within our team has allowed us to leverage a broader array of tools and resources. For instance, by using traffic analysis zones, a tool typically employed in mobility studies, we could obtain granular data at a much lower cost than traditional metrics commonly used in health research. This interdisciplinary approach also deepened our understanding of Cali's demographic patterns, revealing the areas once deemed unsuitable for settlements by urban plans that had become densely populated due to massive migration following natural disasters and forced displacement. Before looking into all that and having the inputs, for example, from social economists, we had a simplistic idea of what was behind all this. And now we have a much better understanding of the context in which we are working. Our work has also benefited from validation and exposure across various sectors. Several team members have presented our findings at prominent events. When we shared results with stakeholders in Cali, they found experts on our team who could discuss complex technical issues as well. Finally, involving diverse stakeholders, including civic organizations, patient representatives, and authorities, has fostered broad consultation and engagement. This inclusive approach has created an enabling environment for the social appropriation of knowledge. For example, our findings have been featured in Colombia's leading newspaper. They have been discussed by Cali's Urban Observatory and highlighted in press releases from the city's foremost public university. I will mention that volunteer collaborators, partners, and key informants agree on a common visual objective, which they find meaningful. Look at the columns in the lower part of this graph, showing inequities in accessibility by housing stratum and how they change when new services were added. We want these columns to align evenly. Furthermore, we all agree we want the map to be painted green. That is a meaningful metric indicating residents' ability to access a service within an appropriate travel time, even during rush hour. We are all aspiring to have greener cities. So now I would like to welcome the discussion and your insights and questions. Thank you very much.
Thank you so much. What a fantastic presentation. And as you mentioned, would love to open it up to questions. Please feel free to put your hand up, and then you can unmute your microphone to ask a question. I know I have some questions. I'll save mine to the end to let participants jump in. But thank you so much. Do we see any hands up? I see some info going into the chat. There's a question from NYC DDC. What is the proposed solution?
Thank you very much for that question. What we're putting forward here is adopting metrics that consider traffic congestion and health equity. And if the question relates to what are the proposed solutions for Cali, well, one of the things that we've done, we deliver two kinds of results. One is showing what is the current situation, and then doing predictions of what would be the situation if new services were added strategically in the places of the city where services are optimized. So what you'll find in the publications for Cali is this is what we found. For example, that accessibility to hemodialysis services is for travel by car in 20 minutes, let's say 45%, according to the measurements we did in July 2020, and that could change substantially, going as high as, let's say, that's 70% adding services in one strategic location. Not only that, we can, in a way, give ballpark figure of how many hemodialysis chairs would be needed to, or what kind of demand would that expansion require. So we can make those kind of predictions or guide information on that sense. That's the kind of application that this could be used. But we are now thinking about is how to do the technology transfer for cities or observatories or civic organizations to build on what we did and have similar tools. Currently, metrics do not consider traffic congestion. So that's one of the things we are pushing for.
Thank you so much, David. Bernie, please go ahead and
Thank
propose
you.
your
Thank you.
question. Thank you.
Well, first of all, congratulations. I think this is really, it's almost like it's a simple idea, but you've used the data visualization so effectively to solve what's such a common problem. And I wonder, well, I have two questions really. One is, have you thought about expanding your research and using your data visualization to think about other issues connected with health and well-being? For example, when you map these lower income communities with negative health outcomes, it often maps with lack of access to healthy food, lack of access to good public open space, lack of poor air quality. There are a number of factors that your research could probably expand to if you had the time and the bandwidth.
Well, thank you, David. I think it's an excellent comment. And yes, we actually have that laid out in our protocol and in our publications. We are doing the test case in Cali with these three services, but we absolutely agree that this could be used for many other things. Actually, we have been discussing it about response to health emergencies, because within a couple of days, perhaps, or certainly within a week, we would be able to point, let's say after a huge earthquake where the infrastructure changes, you could use real-time data to then point to the places where you could put emergency response hospitals so that you can cover the population as the infrastructure has changed. We have thought precisely about what you were saying, looking at where are the markets, where are the family courts and things, the services that people need the most, emergency response, where are the fire stations located, so that a city can ensure that firemen can reach any house within a given threshold of time. So it can be used in many different ways. And the thing is, we were able to do this without external funding, using open data from the city that's available throughout the country in the case of Colombia, but it's available like in 14 other countries in the Americas and certainly abroad. It's been tested in Nigeria, for example, a similar approach, and applied to other social determinants of health. So I fully agree with that idea.
Yeah. Thank you.
Lena, please ask your question. Thank you.
Hola, Luis. My name is Lena. My family's also from Colombia, so it was really lovely to hear what you're doing on the ground and what's going on. I was wondering, in the context of applying this to other cities, how would it work? How would your framework work if you had to also apply data with like public transportation? Because not everybody's getting around by car. And adding that variable, how would that look like, or what complexities do you think would arise from that?
Oh, thank you very much, Lina Maria. And it's very nice to hear that you can connect with this is being done. We could have added other modes of transportation. We chose transport by car because, as I was mentioning, we did this without funding, and we picked what is that people use mostly to reach these health tracer services in Cali. And we found out that it was by car, even for the people that that would have an economic challenge. The risks of traveling by public transportation during the pandemic and after the pandemic, when you have something that's causing immunosuppression, is very high. But you can add other transport services. The data that you have to download is going to be slightly more expensive, because then you have to add another batch that's looking into transport by bus, transport by whatever public services are available, by bicycle. So that can be done. That's not. You'll find this data for most cities nowadays, and that's what it takes. I hope I have answered the question. If not, please
Yes,
let me know.
Thank you. Is it Lenny? Please ask your question. Thank you.
Hello, everyone, and Luis Gabriel. I have kind of a side question here. You mentioned that, something about the funding for the research and the 50 volunteers. Could you outline a little bit more how you did fund the survey, how you did work with the volunteers, just kind of a nutshell?
Well, thank you very much. That's actually the value that we started with. That's why perhaps I emphasized the short video, because what we did was we started talking. It was like snowballing. We started talking with people that could be interested on the topic, and reached out to different audiences, including, for example, authorities. Well, the way of doing it, quite frankly, was I would identify that Lenny is working on this field in her city, and I would tell her, I would like to have a conversation with you because we'd like to have insights about a proposal we're developing. And I would send you the 4-minute video, which we already shared the link in the chat.
Got it.
And the response we got was people saying, I'm very interested in hearing more about this. We also sent an infographic. And that's when we engaged in conversations. And we got a lot of key informants. So we had sessions with 28 groups of key informants for the first prototype, for example. And we got ideas, we got improvements. They chose the colors that work better for the platform and so on. The platform is available live. You can access it from the Padlet or from the publications. And that's how we started building this. And some of these people basically said, I would like to be part of the project. So they were invited. And a key element I would highlight is every time we're going to publish results, we send out the draft. The core group sends out the draft to all the other collaborators, which you'll find listed in the Padlet. And those who want to make contributions, they do. And those who make substantial contributions to the document, they are named authors, and the other ones are acknowledged. So that's how we have published papers, and you'll find that they have large and diverse groups of authors. They have also made presentations. I have not been on many of these presentations. It's one of our contributors in Cali goes and presents to a group of authorities or to the university. So there's that value of having advocates and having other people vouching for the project and presenting this data, which has been very helpful, because I think some of them are being consulted for things like the development of the city's plans. So that is basically you're putting the information in the hands of the people that are influencing or shaping urban health and development.
And the group that, when you say we, how many people are in the core group then, the research group around?
We are about 10, 12 people in the core group.
Okay.
It varies all the time. We have people that are more active in some parts, and then others join. So
I noticed the color palette very much. I took a screenshot of the color palette, and it's quite beautiful. We did research in Cartagena about building communities at night with light. And is it okay if I send you a link to that film at some point?
Oh, it would be wonderful, because I have links to Cartagena, and I hope that that they'll uptake this. And I think the challenge we have ahead is how to do that technology transfer to cities. So that's what we see ahead of us.
Thank you very much for your reply.
Thank you, Lenny. I look forward to that information.
Thank you.
Well, we have more questions. This is like what the platform looks like. Interrupt me when we have another question, but just to show you that we have here the population. We can show here the city where the services are located. In this case, I'm going to show you hemodialysis services. This is all open, and the links have been provided now. So you see here the city, where the services are located in the city, where the population is located, and you have to the right here the demographic characteristics of the population per the census. So you have here absolute numbers and relative numbers. And here you have the traffic congestion levels and the matching hours for that week in which we made that measurement that I'm showing you here. So what happens when you set up a threshold of 20 minutes to reach those health services? Well, that the accessibility goes down. This is at the peak traffic hour, but you can see that Cali is a very busy city because these hours are almost peak traffic as well. And you can see how there's a huge difference by socioeconomic stratum of the housing in accessibility. So the poorest people, their accessibility to hemodialysis could be 13%, while higher income groups have a much higher accessibility. You can also look at this by ethnic groups, by education level, which of course is related to income, and so on, or by age groups and gender. So that's how we get our information. We can look at what happens at free flow traffic hours. The map completely changes. So that tells us the situation. But when we look at what are the predictions that we can make, well, we can show what would happen if we add services in one sector of the city. What is the ideal sector to do that? Here it's telling us is this sector of Aliria Mora Beltran. And you would see the changes now on how this is much flatter. So there's more equity. Many more people are accessing the services. They improve, especially for low-income housing population. And what would be the improvement for the entire city, which is very significant, from 45 to 70%. But what happens if we do that for two placing services into sections of the city, and you can see a huge difference. So that we had that for each of the services that we tested in what we did in Cali. And we did measurements at 2 times during the pandemic, in July and November, and there were changes because there were stay-at-home orders in November. So you could see changes in traffic congestion.
May I jump in and ask a question, please? I'm really curious if there is any flexibility with healthcare facilities in terms of their knowledge of traffic congestion, if there were discussions with them about the ability to have extended hours, things like that, or any type of grace periods when patients are going to be late for their appointment, and being flexibility and being able to reschedule given their proximity to these healthcare services. Were you in any discussions with those facilities on that?
Yes, and they do offer long hours. So that's a way of mitigating the challenges of getting to those services. However, that's how we learned as well, that some of them have tried to put services in the areas of the city that are currently kind of deserts for those health services. They have tried, but the land use plan would not allow it. And that's because that area of the city, as I was conveying, it was not expected to be inhabited because it's under the water line of the river. The big Cauca River is huge. So it's an area that if the levee ever breaks, is going to be flooded. But that's also an area, Cali is in a high risk for earthquake zone. And that area, because of those conditions, if there's an earthquake, the soil would liquefy. So it's an area that's not suitable for buildings. They would have to find engineering solutions to build those buildings there, or see if where they have already built hospitals, second level and first level hospitals, not tertiary care hospitals, but the other institutions, if they can revamp, and we can give predictions for revamping. What happens if you repotentiate a hospital so it has those services that are missing? So those are other options that were considered. So yeah, the other thing, Naomi, which is important, is if you're living in the outskirts of the city, having the possibility of going to your hemodialysis at midnight, it's a lifesaver in a way, but it's also amplifying some inequities, because then you have to travel at dangerous hours. It's going to make you cannot sleep that night. This is 3 times a week for people in hemodialysis. The treatment takes about 4 hours. So you have to add 1 hour getting there, 1 hour getting back, and 4 hours. What's the quality of life impact? So the interesting thing that we're bringing here is that I think most of urbanism projects would focus on how to reorganize the dwelling places, the residences, and create new sectors of the city that are more densely populated and have services. Here, we are focusing instead on where to strategically place services, how to create incentives, creating incentives for or getting that information out of where these places would reach everybody. In Colombia, everybody has, or almost all the population has, health insurance. So for the providers, that's also an opportunity, because if the land use plan changes, they have an unattended market that if they place services there, they're going to capture a huge amount of the population. For hemodialysis, we estimated that that would be like capturing almost half of the population that needs hemodialysis would be captured by placing strategically services there. So they would need to have big services, and that would facilitate services also for people in the metropolitan area and neighboring cities that use Cali as the resource for that. Another element related to what you just brought up, Naomi, is that the city or the country is beginning to offer subsidies for people to attend treatment. So you get a subsidy which is the same for everybody. If you live a block away from the service, or you're wealthy, or if you live in the outskirts of the city and you struggle to make a living, that subsidy is going to be the same. And tools like this could be adapted to provide a more equitable delivery of those subsidies, so that the people that really need it the most get more.
Thank you very much. Mariana, I think you had a
Yes.
question. Yeah.
So are
thank
you in conversation with, the authorities that are, how was your study received by public health authorities and urban planning authorities? Does it look like they're gonna do something about it?
We are very optimistic because they already included the findings and the recommendations in their in their city's development plan, which was approved, the 2024-2027. It's also part of the academic background supporting the city's land use plans. So we hope that they'll consider it. They have attended for example, the devolution of results in Cali in September. And several of their advisors have been supporting the work, or have been involved in some way in the work we are doing, or I would say they took it with curiosity, and they are really interested and genuinely interested in on this. So we are hopeful that this will lead to change. For us, publishing results in 2024 and that same year, seeing some of the results permeating some of those policy documents is a very good sign.
No, I've been involved in working with the public sector in Uruguay, And the dangerous part is, politicizing, that it becomes like, the flag of some political party, because when the next one comes, they try to shut it off, even though it's a good tool, but I hope that doesn't happen.
You are absolutely right, and we're hoping that the engagement of civic organizations like Pro Pacifico in Cali, for example, that are supported by entrepreneurs and support the government as well, and of communities. And there's a huge opportunity now in Cali. You see the city is moving from having 24 communes to having 6 minor major offices, I would call it 6 localities. And that's a great opportunity, because when you look at where the services are placed, it's pretty obvious that they're basically most of them in one locality. That gives an opportunity to the incoming local leaders to raise a whole discussion of how we can have a fairer distribution where we all benefit from these services. So I agree that there's always these risks that this gets politicized. But at the same time, I think that by engaging the civil society and other stakeholders, we can keep the interest on addressing this issue and showing, well, also the value of, I was mentioning Cali went through social unrest, and this is an issue of social justice and we hope that this brings the possibility of engaging the entire society, because then you have a more productive society eventually. I mean, that's the idea of, there's also a pragmatic approach to it in terms of social justice. So
Like you
we'll see how
said,
it goes.
when you engage the business side, when you engage the health insurances, and that's also guarantees it's like long-term.
It was one of
Because
the CEOs
gonna
of one of the hemodialysis firms that, for example, brought the whole issue of, we want to put services there. We just need the approval of the land use plan to allow us to do it. So I think we're working with all these different stakeholders. Hopefully we can find those win-wins for government, society, and every other sector. But it's a bet. We'll see how it works.
Thank you so much. No, that a great discussion. One of the themes that I heard going through your presentation was something you said early on about complex ideas, translating that into simple script so anyone can understand, and in your case, using animation. We just have a few minutes left, but would anyone like to kind of share examples of how they were able to translate their research into, simpler terms for anyone to understand? And of course, this is very well aligned with the thought process behind the Sustainable Development Goals. Those infographics, something that's easy to interpret. So if anyone wants to jump in and just share some thoughts on that, that would be great. Oh, Lenny, please.
Yeah, I just want to say that this is one of the most difficult challenges. We work with light and night in cities, and describing the issues, the social, economic, and health issues about nighttime and about lighting is just, where to bring it down, to what level to make this new field understood is truly a challenge.
Yeah, thank you for your thoughts. Please.
Well, I think one of the things we became very aware of, all of us in the collaborative group, is that providing the evidence and providing the science, that's just one of the elements that is involved in a decision. And there's many valid reasons why policy decisions may not be the evidence. All those issues around how forced migration that happened in Cali, brought perspectives that we had not even thought about. When we started this, we thought it was segregation, racism, whatever that was keeping these services all in the wealthiest part of the city. But then we learned how the city had grown. We got a history. We got inputs from these social economists and historians, Enrique Sinisterra and Harvey Vivas, and they brought incredible perspectives, Francisco Ramirez, and then we learned, well, there's a lot more behind the decision, and the evidence might be helpful to inform what is needed, where it's needed. But at the end of the day, they'll have to look also where they can place the services, and they may find that there's a lot owned by, let's say, by the district, by the city. That's not exactly where we pointed, but it's in a place that is anyway has a huge impact in improving things, and that may be more appropriate than actually coming and tearing down who knows, a church or a service, because that's where the point fell when we made our predictions. So I think as a researcher and as a health person, we have to come and look at this with the humility of knowing that there's other sectors that will have many other valuable inputs into a decision of how this can be addressed. So we provided the best possible science we could, and now we have to look at what else helps address the issue. But now the issue is visible and it's measurable. And what we did is, let's say, cheap enough that could be used for monitoring as well. So that puts the cities in a stronger foot to address health equity issues and social justice issues. And as David was saying, not just with the health sector, but beyond.
Thank you so much for that response. And I'm just having a look at the time. These discussions can, of course, last for a very long time because they're so interesting and we're all very engaged in this subject. But I do want to thank Dr. Cuervo so much for this incredible presentation. And we are so glad you listened to that buzzing that was going on in your ear and you took that walk in the woods, which was the start of all of this incredible research. And also best of luck in your doctoral studies. I would also like to thank CSU's Michelle and Mariana for bringing this together. And thank you to all of the attendees for joining us today. And we really look forward to seeing you at our next Green Cities event. Thank you so much to everyone and be well. We will share the recording. Thank you.
Thank you, Naomi. And thank you, Dr. Cuervo.
Thank you all very much. I'll invite you all to visit our Padlet and our LinkedIn page and stay abreast of how this evolves.
Thank you so very much.
Thank you. It's wonderful to be here. Well, thank you all for the kind comments and seeing on the chat and the wonderful questions and insights that you shared with us.
Absolutely. And if you're open to it, we can share your LinkedIn for those who would like to connect with you if you're okay with that.
Yes, please.
Great. And we'll also go through the comments to see if there's some interesting projects that people were discussing that we can save and share with you. All right, we have a few more participants still on. I will log off, but Luis Gabriel would love to stay in touch. We can chat offline. And thank you again to everyone for being
Thank
here. Have a nice afternoon. Take care.